All right, so welcome back. This is the second part of the activity and exercise module. So we are looking at common assistive devices for walking. And the first picture shows you a patient in a walker. In the home, many patients prefer walkers with wheels or short runners on the legs that allow them to push the walker. Remember, a person's cane length is equal to the distance between the greater trochanter and the floor, and have the patient keep the cane on the stronger side of the body. Crutches are often needed to increase mobility, and it's important to begin crutch instruction with guidelines for safe use. Teach the patient not to lean on crutches to support body weight. Teach patient with auxiliary crutches about the dangers of pressure on the axillae, which occurs when leaning on the crutches to support body weight and can cause nerve damage. Explain why patients need to use crutches that were measured for him and her to ensure safe patient mobility. Explain that the crutch tips need to remain dry. Water decreases surface friction and increases the risk of slipping. Show patients how to dry the crutch tips if they become wet. And also show patients how to inspect the structure of the crutches. Cracks in a wooden crutch decrease its ability to support weight, and bends in aluminum crutches alter body alignment. Measurement for auxiliary crutches are shown on the top left, and the photo on the right shows using the goniometer to verify the correct 30-degree of elbow flexion for crutch use. Verifying correct distance between crutch pads and axillae should be 3 to 4 finger widths, as shown also in the right hand lower picture. And the next picture is the tripod position, which is the basic crutch stance. When crutches are placed about 6 inches in front of and on both sides of the feet, this is the tripod position that you will see. This should be the position used before walking, and again, the patient should not be using the axillae to bear weight. Determining the crutch gait for the patient should be based on patient's abilities and reason for the use of crutches. We will review some common crutch gaits. The 4-point alternating gait shows solid feet and crutch tips show the order of foot and crutch tip movement in each of the 4 phases. The patient bears weight on both feet and the leg is moved with the opposite crutch. The 3-point gait with weight borne or on the unaffected leg. The affected leg does not touch the ground with this gait. And finally, the 2-point gait with weight borne partially on each foot and each crutch advancing with opposing leg. Solid areas indicate leg and crutch tips bearing weight. So now we're going to look at using crutches on stairs. This is a modified 3-point gait, and here we see a nurse helping a patient descending ascending stairs. So, weight is placed on the crutch in figure A, and then B, weight is transferred from crutches to unaffected leg on the stairs, and C, the final picture shows the crutches are aligned with unaffected leg on the stairs. Remember, when going upstairs, the affected leg is moved last, and when going down the stairs, the affected leg goes first, and by doing this, the patient keeps the weight bearing on the unaffected leg and the crutches. So the second slide just shows you again descending the stairs, and here we see a nurse helping a patient descend stairs. The body weight is on the unaffected leg, and the body weight is then transferred to the crutches, and then finally the unaffected leg is aligned on stairs with the crutches. In this slide, we see a nurse helping a patient sitting in a chair. Both crutches are held in one hand. The patient transfers weight to crutches and unaffected leg, and then the patient grasps the arms of the chairs with free hands and begins to lower herself in the chair. And finally, the patient completely lowers herself into the chair. Research shows that activity and exercise play a role in secondary prevention or reoccurrence of coronary heart disease. Low to moderate intensity aerobic exercise is most effective in lowering blood pressure, whereas weight training and high intensity aerobics have minimal benefits for hypertension. Some patients are fearful of participating in exercise because of the potential for worsening dyspnea. This aversion to physical activity sets up a progressive deconditioning in which minimal physical exertion results in dyspnea. Individuals with type 1 diabetes need to exercise because it leads to improved glucose control, cardiovascular fitness, and psychological well-being. When evaluating outcomes, the patient is the best source of information about effectiveness of benefits of activity and exercise. You also want to look at the patient for signs of improved inactivity and exercise tolerance. Again, seek their perception of how things are going and ask if their expectations are being met. So this concludes this module. Thank you.